First, we'll start. Just tell us who you are, what makes us want to listen to you about PMOS.
I am a family nurse practitioner. I graduated way back in '04. My primary specialty was family practice.
Okay.
I didn't like it. I didn't like spending 6 minutes with a patient and being told by insurance what to do, and there were very much protocols that we would have to abide by. So that encouraged my shift away from family practice into plastic surgery, honestly, because in plastic surgery, you help everyone, right? They come in with a concern and you make them better, and it's a really elective procedure and very good outcomes, right? In primary care, you don't always get those outcomes, and it was frustrating as a new provider. That's how I got into plastic surgery, which led to non-surgical interventions to make ourselves feel better, including injectable stuff. As a family nurse practitioner in this field, you would ignore a lot of medical concerns, which was a problem, right? Patients come in and they say, hey, I'm tired. Give me some Botox, make me feel like I don't look tired, but really I'm tired.
Yeah.
For years, you almost feel like you're kind of ignoring a certain aspect of healthcare in that. To be really honest, I see patients 3 to 4 times a year, and that's more than their primary care provider.
Oh, for sure.
As a medical provider, I'm actually seeing patients and hearing a concern that I wasn't really treating. Then I was unable to treat certain conditions fully, because if someone comes in and they say, I really want to snatch my jawline, but they're inflamed, the worst thing I could do is put a bunch of filler in there or, sell them something when I really should be talking to them about how to become not inflamed to improve their aesthetic appearance, because we see appearances as we get healthier. I struggled with this as a provider, but I really like working with my hands, so it's a fun thing to do, and I like the outcomes, and I enjoy my patients. As I got older, I also started feeling the same way. I started getting really, really tired, and I felt like I was being ignored by my own specialists. This is not a knock at the healthcare industry, because I realize they're operating within insurance realms. They have to see so many people a day, but I have Hashimoto's and I was exhausted. And then I hit perimenopause. And I decided that I wasn't going to be able to survive and stay in medicine if I felt this way. I wasn't going to be able to pour out to someone else if I felt really bad. And I realized that the way I had been treated was not the way I wanted to be treated. So I decided to go back to school. And that's when I went to functional medicine certification program with the International Board of Functional Medicine to try to figure out if maybe my diet and my lifestyle could really be influencing, what I feel like. And then I also decided that I needed hormones, so I'm focusing on bioidentical hormone replacement. That's how I landed here. With PCOS in general, I started seeing patients in practice, and those were the hardest patients. So PCOS became a challenge for me that I really wanted to learn more about. And I realized that what I had previously been told about PCOS was not even close to the tip of the iceberg. And we were just starting to kind of realize the full extent of the problem. That fast forward is a really long way of me telling you, why should someone listen to me on this? I'm not an expert. I think that's the most important thing, because I don't think anyone really is right now. I think we're still trying to decide how to treat this massive beast, right? What I will say is, to any provider out there, we all should be talking about PCOS. It doesn't matter who sees you, right? Because it could affect your mental health, your cardiovascular health, your reproductive health, your endocrine health, your metabolic health. Trainers should be talking about this. Nutritionists should be aware of this. And we should all try to hit touch points on PMOS and realize that it's going to be a collaborative effort for these patients, because it's so much trickier. Not a proclaimed expert in this field, but I do think we should shout it from the rooftops that we should all be kind of trying to dig into this as much as possible.
Yes. And it's good that you said that you're not an expert, but you're learning. As a patient, I know that you do your research behind everything you do. And I think it makes it worth it from a patient perspective, because you've gone through something, not PC or PMOS, but you've gone through your own thing, and you're like, I don't want to be treated like this. I want to treat my patients better than this. So that's why we should listen to you, and that's why we're here today listening to you.
But just know that maybe part of it might be me connecting you with the right person or getting outside information. I have a patient I'm collaborating with their OB-GYN on, because it's a challenge, right? I realize we need more help. I think that's really important for providers. The minute we think we know it all about something is the minute that we're dangerous providers or negligent providers. I have a lot more digging to do on PMOS.
Yes. But you're willing to do it, and
Absolutely.
I appreciate that. There are a lot of people that I know, they said, I didn't even know about PCOS or PMOS until you mentioned it. Can you tell us what PCOS/PMOS really is, and what you think about the name change, which happened in May of 2026. Tell us a little bit of that and break it down to where we can understand it.
Traditionally, this was called Polycystic Ovarian Syndrome. I think the name had a lot to do with how it's been treated in the past 20, 30 years. This is something that I think was kind of debated in the specialty industry. It felt kind of like, oh, you know, it is a reproductive issue, but it really is endocrine. I need endocrine help. And then endocrinology was like, it's kind of more of a reproductive thing. I think it kind of got punted a little bit, and there really wasn't that holistic treatment. We've also had a big push in the past 50 years of medicine to be more specialized and not look at the whole picture. The inherent problem with PCOS is it was really focused heavily on this concept that you would have all these ovarian cysts. And if you didn't have that, it was kind of like, well, you don't really have this. The literature shows that PCOS is affecting just a lot more people than we think. As many as up to 70% go undiagnosed. It's really a multifaceted, you know, kind of metabolic, endocrine, reproductive problem. I think by changing the name, this polyendocrine metabolic component kind of started to emerge. It started to realize like this is a more, you know, complicated condition, and we need to look at it from multiple different specialty angles. That's where I think the name change was needed.
I think that was one of the things, not to interrupt, but Polycystic Ovarian Syndrome. When I first heard about it, which was back in 2011, my doctor was OB-GYN, and she was just kind of like, hey, she wanted to prescribe all these different things and with birth control. And I'm like, I'm not doing that. She was like, oh, well, I'm trying to treat your PCOS. What is that? I'm like, you never even told me about it. And it was like, oh, PCOS, Polycystic Ovarian Syndrome, is a misnomer. There are no cysts. It's literally a follicle your egg didn't mature, right?
Right, basically multiple of them, because there's a lot of that immature follicles.
Yeah, somebody told me your ovaries look like tomatoes on a vine. That's what it's supposed to look like. When I think, again, once I started coming to you and give us so much information whenever we come see you, and then you realize the name change, Polyendocrine Metabolic Ovarian Syndrome, you're like, oh, this is so much more than just reproductive, than just cysts. It's so much more. It's a whole new world, and people don't understand how serious it really is. It can affect, like you say, your cardiovascular, just everything. And I definitely feel it with being inflamed sometimes or bloated, and so much more than that.
Cyst, quote, that is a symptom of this polyendocrine metabolic condition that's going on in your body. That's related to insulin resistance. It's related to inflammation. Those are the two biggest drivers. And if you were approaching this just with birth control, you're going to shut down the production of your hormones, right? Which temporarily eases some of the symptoms of maybe the heavy periods, right? This is another aspect, is these women sometimes have had heavy periods, bad PMS their whole lives, right? And they can be progesterone deficient their whole lives. When you give them birth control, it sort of shuts down those symptoms, but it doesn't really get to the root cause of why they're having these. And so they can have long-term high insulin levels, high inflammatory levels that we're really not addressing with just birth control. And sometimes they would find the insulin resistance as it started to impact the hemoglobin A1C, the average blood sugars, and then maybe they would start them on a metformin, right? So this was kind of the recipe, but it was lacking. We didn't include how important it was to bring down the inflammation. We didn't include how important it is to really get that insulin down. We also didn't take into account for these patients how hard it is, how much of a wall they hit. It wasn't until I started treating patients in clinic for weight loss that really showed that we would start a typical weight loss medication that was really effective for one person, and that person with PMOS would lose maybe 10, 20 pounds and then hit a wall. It's way more complicated than that. And really trying to get to that root cause, there's a little genetic influence, there's lifestyle influence, there's stress that impacts it all. It can be this thing that looks different for everyone, right? One person can look one way, the other person can look another, but deep down we have to get the driver of that. It may or may not have anything to do with you showing these cysts, these immature follicles.
So with all of that said, and I know that you said because if you have PMOS, you don't necessarily have to have cysts.
Right.
So what are some of the symptoms, if you don't have PMOS, what are some of the symptoms that may trigger you to go get tested? If you have PMOS, what are some things maybe that you should look out for?
Traditionally, they have PCOS or PMOS. You would need to have irregular periods, two of the three, irregular periods, high androgens, or these cysts on the ovaries. Even the diagnostic criteria have been a little limiting in the past because you may see someone that doesn't have elevated androgens, that's like elevated testosterone or DHEA. You may have someone that is now on birth control, so maybe their periods are quote unquote regular because they're being masked. And so that can postpone the diagnosis if that makes sense. Or you can have someone that maybe never had the ovarian cyst. So I do think the diagnostic criteria limits us. And I think that's really Something that, once again, no offense to Western medicine, but we try to put things in a box so that we can move really fast so insurance can reimburse the clinic. It's really hard to make money in primary care. Volume is the key. So when you really look at the new current data on PMOS, and when I go to my lectures, they really look at the whole picture. So if you have someone that, you know, as a female, and it is a female condition, so that goes without being said. You know, we forget to tell men that this is not for them. A female who maybe has always had heavy periods or irregular periods, they don't follow a typical pattern. Females that maybe had a history of facial hair, or maybe they had a lot of acne. Those are signs that they could have had elevated androgens or elevated testosterone or DHEA.
Is the acne specialized in a specific area?
Not really. It could have back acne or face acne. It could be in different areas, not exclusive to one particular kind of presentation. Maybe that person has also struggled with weight, right? And I see a lot of this in younger girls, and they're athletes. They are soccer players. They're running, they're exercising, and they're thicker than their female counterparts. They just ask me, and this is a really hard conversation when I see, and I have seen a lot of daughters of my patients who we suspect is on that PMOS spectrum. I call it a spectrum because it's not definitive. It's not a box. Those people may have always felt thicker, may have always felt heavier, and may have always also experienced shame from their parent in, you're eating too much, right? There's a lot of that, and I've talked to parents who have felt guilty for that, or saying, I just thought she was like closet eating. There's a lot of weight shame in our environment and a lot of blame on, to be really honest, you look at a teenager's diet, half of them are surviving on M&Ms and Takis, you know, and you know, like, and it might not work for the next person. You'll see that girl who's struggled with her weight and her appearance, and despite being super athletic and active, and I saw that a lot growing up with my female counterparts. As they get older, you might see that they get on birth control. So their 20s, it's a struggle because these things are kind of masks. So they might always just think, oh, I'm just not motivated or as likely to lose weight for whatever reason. You see a bit of depression and a bit of acceptance of this is just my body, right? And then you see them when they try to have babies, that it affects their fertility. We see that, I heard from one lecture that this could be the #1 cause of infertility. That's a big deal, right? And not really addressed in the right way when we go to try to get pregnant. And later on, maybe they didn't have problems with infertility, then they enter perimenopause, and that's when it really blows up, right? PCOS can feel and look like perimenopause way before it happens. So my patients who are mid to late 30s are coming in and saying, am I in perimenopause? Or is this PCOS? It's really hard for me to answer that because it so mimics one another. And they'll come in for weight loss and they'll say, I really am doing everything. As a provider, you believe them because you know them, because I spend an hour 3 times a year with them. Like, you know their juice, you know their teeth, you know what's going on in their life. And I know that they work out with the trainer. Also, I follow them on Instagram. They follow me. It's a personal connection, and you see them working. They're working harder than I am in the gym. I see that on you and your husband. I'm jealous. Like, you guys are ballers and badass at the gym. I'm not doing that. I need to be pushing sleds. But you can see that, right? That's the ability of a personalized connection with your patients. And so you start to go like, yeah, this isn't adding up, right? Something isn't making sense.
And I think, like you said, you hear that from your parents if you're younger, even if you're older, and even from some of your family members too. It's like, oh, just do this and then this will happen. Going back to the fertility part, we've struggled with fertility, and people would say, oh, just take Geritol. It worked for me. Or, oh, just do this. Oh, just have a lot more sex. Or, oh, just, and it's like, guys, it's not that simple. You know what I mean? It's like you have all of these other factors that, shoot, the person that's going through it doesn't even know about. Right. You experience all those things and people just don't know. And I think it's important, you know, and that's why we're doing this too, is to educate people and say it's not that simple. It's so much more, and it's so much more complicated. That's why more research and the name changes is a big deal.
In a conference that really spoke to me is that we treat every woman like they have PCOS until we prove that they don't. That's almost like probably too aggressive for a lot of these providers out there that are really in this insurance world. But me, everybody that sits down in my office are more advanced because they're already saying, hey, I need something else. I need a deeper dive into my health because something isn't working for me. So that's my patient already in a nutshell. I already have to suspect that this could be the case. If we assume that 70% of the patients are undiagnosed, then that's a high percentage. When someone sits in my chair and they say, you tried this the traditional way, we have to suspect that. We have to start looking for that. And we have to start looking at other signs that could point to that may not be traditional, right? Could be your thyroid too. People with low thyroid, low progesterone, people with nutrient deficiencies, people with gut dysfunction. All of those patients could have PCOS or PMOS. Those are kind of like the untraditional methods of looking for it outside of those 2 of the 3 diagnostic criteria. I'm looking looking to see, when I run your female hormones, is your luteinizing hormone higher than your follicle stimulating hormone, right? That's a key indication for me. But it's not always there, right? It is tricky. And so I think we just have to suspect it with every woman, especially a woman who's had a challenging history.
So going back to what you said with the labs, are those that you kind of look for to see, do you have PMOS?
I kind of do a more comprehensive panel to look for a lot of signs or risk factors for PMOS. So sometimes we're looking for things that could contribute to it, and sometimes we're looking for things that identify more likely PMOS. That is, it's your thyroid, it's your vitamin D, it's your insulin. Fasting insulin's a big one for me, because you'll have someone with a totally normal hemoglobin A1C. Their average blood sugars have been normal, but their insulin is really high.
Okay.
And then you'll also see high elevation of inflammatory markers like CRP. We have to kind of figure out, our limitation is how expensive some of these tests are. I try to contract pricing to get better overall pictures. There's so many other labs I would like to do, anti-malarian hormone, all of the inflammatory markers that can be so pricey to draw. I would do all of it on everyone if I could, but we have to decide, where can I get a good idea of what's going on with this person? What is their progesterone level? And you're trying to time sometimes hormones with their cycles, but if they're not cycling regularly, it's almost impossible to do that. So sometimes we'll look at a more advanced test, like a Dutch cycle map, where we look at the hormones for an entire month, because that way we can get a better idea. But once again, that's like an $800 test, so you're limited. So a lot of it is trying to find those signs and symptoms in the most cost-efficient way possible to try to impact that patient. Usually they'll have a history too. They'll say, I was diagnosed with this. So that does make it easier for us to go ahead and move forward and say, all right, let's treat this as such.
Do you see a particular age that have already been diagnosed? No.
No, I don't. I think a lot of it was missed, because I think so many women were placed on birth control that it postponed our diagnosis for a long time. The common thing to do for a young woman or start their period, even in high school, is to put them on birth control.
Yeah. And
then they're blunted, right? And then the symptoms are masked. Maybe they think they're just overweight, or maybe they're not, because that's the other misconception. You don't have to be overweight to have PMOS. Yeah, so I think that we see a lot of delayed diagnosis. My goal for younger women that come in is to try to monitor them for it, to hopefully not develop it, or to identify it as soon as we can.
So that goes into our other questions. You said not develop it. So is that something you're born with? Can you ever cured from it?
The general consensus in the literature is that there's a genetic component and there's an environmental component, and they don't know what comes first, the chicken or the egg. I think certain people are more environmentally at risk for this, and there are certain people more genetically at risk for this too. So if it runs in your family, if your mom had it, your sister has it, there's probably a genetic component there. You will see one sibling develop it, one sibling not develop it. Genetics are kind of hard to kind of go by. I do think lifestyle interventions, especially early on, can possibly help control it. I don't think that you're ever cured of it, right? If you have a predisposition towards something like diabetes or PMOS, I think we're always trying to fight it. And that's my belief based on what the literature has shown. You can control it. I don't think it's cured. I think that's your battle that you're fighting. That's been what I've read.
Can we talk a little bit about inflammation or bloating? Is that a constant if you have PMOS? I know I experienced it. We've talked about it before. I've done the Whole30, and when I was on the Whole30, I didn't experience inflammation or bloating. And I know how that feels, but for somebody who doesn't know, how does that affect them, or what should they be feeling?
Very good question, because one of the main key drivers of PMOS is inflammation. One of our biggest tools to try to control the PMOS is to bring down inflammation and to bring down your insulin levels, to get you more sensitive to insulin. When we talk about inflammation, we think of it more systemically, right? Someone could have inflammation and absolutely not feel it, really. I think bloating is kind of a separate feeling that could be more associated with inflammation in general, or associated with the gut dysfunction. There's a high level of gut dysfunction that tracks with a lot of PMOS patients that also contributes to the inflammation. Our gut dysfunction, our feeling of bloatiness, is leading to actual inflammation of the body. To your point, you could feel inflamed. But someone could also be very inflamed and also not really feel it. I've had a lot of people experience dysfunction and gut dysbiosis. And they feel totally fine. I'm one of them. I have a messed up gut. I tested it. I know how messed up it is. I can eat all the gluten I want. I don't have feelings of bloating or bad feelings, but I have autoimmunity that's getting worse. The stool test showed it. So when you are asking, what do they feel? If their gut is dysfunctional and you're eating foods that are really inflammatory to the gut, you're gonna feel super bloated afterward. That's why we undergo such an extensive gut protocol when we're talking about PMOS patients. Then we can have this whole separate thing that is systemic inflammation that we need to measure for in the blood work, that is leading to more driver of fat being stored in the body, and then that leads to more inflammation, especially visceral fat or fat around the organs. Inflammation, I think I sent you the article talking about it's very wordy and scientific, but inflammation is one of the biggest drivers. So there's a bunch of different ways in which we work to try to bring down inflammation. As we do that, it also brings down the visceral fat. It helps you become more sensitive to your insulin.
Visceral fat is bad fat, right?
Yeah, bad fat in your organs and around your organs, and it's like a metabolically active fat, but in a bad way. Inflammation in general is also a driver for a lot of high-risk heart disease in the future. It's also a driver for cancer. What we know about PMOS patients is you have a higher risk for breast cancer and endometrial cancer. When we have an inflamed body, a low thyroid, low progesterone, and all this inflammation in the body, we are setting ourselves up for a more likely risk factor for an event to occur. It could be cardiovascular, it could be cancer.
And with inflammation, as far as your diet, are there certain things that are this inflames everybody, or is everybody different?
Everybody's different, but there are some knowns. In general, we start with what are the knowns. We know that for whatever reason in America, we're seeing a lot of inflammation from grains and gluten. And we don't know if it's because someone's truly sensitive to gluten or grains, or if it's because of the pesticide sprayed on the grains. We haven't quite figured out that. We see a lot of people sensitive to it, and when they stop it, inflammation starts to come down. Same thing with the processing of certain dairy products. We're told our whole life to eat dairy for our bones, but a lot of people it's very inflammatory. And then there's a lot of processed foods that include a lot of seed oils and other ingredients that are very inflammatory. Those are the kind of top three in general. If we're trying to reduce inflammation in the body, we want to work on that. In general, we want people to eat real food. So if it didn't grow, fly, swim, if it didn't look like it came from the earth, then we probably want to avoid it.
Stay away from it.
In America, we've just moved toward this highly processed, highly chemical food.
Fast.
It is, it's fast, it's quick, and it's shelf stable. And we did that to prevent famine but at the expense of our metabolism. All the foods, basically, even healthy foods that we think are good, most yogurts, most cottage cheeses, they're just encouraging the inflammation. And so it really has to be a reset of how you were ever trained and thought. And civics get into that. So we tend to say, oh, high protein, right? Protein at all costs.
Yeah.
But what if that person isn't absorbing protein? What if they're eating too much red meat? This person was me, by the way. You can produce TMA that goes in and starts attacking the joints and makes your autoimmunity worse, makes your inflammation worse. Sometimes we have to be a little more specific on the diet based on that person's symptoms. But most people need to start at the top, which is trying to eat real food. We'll see a lot of reversal of inflammation with that.
Okay. We're going to get into just a quick rapid fire. I'm just going to throw a few statements out at you, and you can tell me whether they're fact or fiction. And of course, if you want to add to it, please do. Does having PMOS mean you're automatically overweight?
Fiction. Sorry.
Okay, fiction.
False. No, there's a skinny PCOS type patient. That is definitely a misconception. You may not have weight problems at all if you have PMOS.
So does it make it harder for them if they are, if they're overweight? Well, when you're overweight, you can lose weight and maybe help manage it better. But when you're not overweight,
it can be a lot more difficult. Maybe they have more thyroid dysfunction, and that's really driving their anovulatory cycles. Some of the treatments that help, like the GLP-1s, right, you're limited on that person who is of normal weight because you don't want to get them underweight. And so you have to change up a little bit of what you're doing. Most important factor is it delays diagnosis, right? They're less likely to seek help. If you haven't been overweight, you feel healthy, you may not go and seek diagnosis, so it could delay the care.
Is PMOS something you're born with, or does it develop over time? And we answer this, but fact or fiction?
I would have to say it's fiction to think that it's one or the other. There is a genetic component, and then I definitely think your lifestyle is influencing it. I'd love to see breakdowns of socioeconomic status and PMOS development, because I do think that the families who are used to sitting around a home-cooked meal table, I was very fortunate to be raised in that environment. My mom cooked every night versus a fast food family. I had friends and they would literally eat Jack in the Box every day. It's crazy to think of that, but that's how a lot of people grew up in our generation. I grew up in a non-wealthy area, so money was a factor on that. I do think that lifestyle is greatly influencing that from a young age. Hopefully the food movement pushes us back toward that.
I wonder also too, now that you say that, if that even exacerbates PMOS, if it's just there dormant and then
Absolutely. Absolutely it does. Because I think if you had someone that had PMOS tendencies, just like diabetes, but they were really strict or really just had really good habits with food and exercise, they may not develop that for a long time, maybe not even until they're older and they finally get sedentary. Absolutely. I think that lifestyle is probably the most important factor. Just like we talk with cancer, just because your mom had cancer doesn't mean you're going to get it, right? We have a lot of ways to prevent that. And I think that's where we're failing in medicine. We're not preventing, we're early detecting. We're treating.
Reactive.
Yeah, we're reactive.
Do all women with PMOS have insulin resistance?
No, I think that that's important to understand is that you can still have PMOS symptoms even after we've gotten the insulin resistance under control. Okay. They may still have high inflammatory markers, or they may still have thyroid dysfunction that's really driving it. What I've learned, and the biggest takeaway for me in my PCOS experience, is really looking at that thyroid component too. Sometimes you think you're doing it, we're getting the inflammation down, we're getting the the insulin resistance under control, and lo and behold, their thyroid is really messing up their ovulation and their ability to cycle normally. Okay. In the absence of the insulin resistance, you can still have issues that contribute to the PMOS.
Can you reverse PMOS with diet alone?
I believe you can. I believe that it's hard though. And so I do think that I really want to be clear with women that have PMOS. We put so much pressure on women. Just work on your diet, work on the exercises. We don't really give you any advice on that or how to do it. I think it's very difficult, and that's my big soapbox I'm gonna stand on, is I do think you need help. I see people, even with help, it's still a struggle. So yes, it's possible, but it also can be very challenging and hard. So I don't want those women who haven't been able to control it with their diet and exercise alone to feel some sort of failure because of this. You may need thyroid support. You may need help getting that inflammatory level down. You may need some help with that insulin. It's not a failure to ask for that. And that is the difference in functional medicine versus holistic and naturopathic, is that we do believe that when you need a medication, an assistance, or a hormone, that we can use that. And that's why we have advanced medicine. And so I fully believe that as a functional medicine expert, I do believe sometimes you need help. And sometimes you need so much help that it's the next level. We bring in endocrinology and gynecology, and it is all of our heads together trying to make this happen for this person. I want that to be very clear to patients that yes, the diet and the lifestyle are probably the most important components for you to do at home. But just know that it's also important to ask for help too. If
that's that wall you're talking about. If you hit that wall and you've done absolutely everything, it's okay to reach out to Melanie Frye.
Or your provider. There's so many women that are struggling with this. And I think that it's not to give you, I want to give you hope, because sometimes you just need that little extra help. I used to say I enjoyed plastic surgery because if someone had a baby and they came in and they got a mommy makeover, immediately they felt better about themselves, and then they would go to the gym and work out. But if you're trying to go to the gym and you're like, God, I don't feel good in my clothes and all of this, it's hard to keep going when you're not seeing any improvement at all. It's really important to ask for help. And they're asking for trainers. That's why I think all of us need to be aware of this, because the help may come from a different source. You may not recognize that the gym you're going to might have a PCOS patient in there who's working out beside you, and maybe they're your source of information. And so that's why I like what you're doing with your social media.
Well, thank you. I appreciate it. Thank you. Thank you for always supporting me too. Does everyone with PMOS, we talked about that, have the same symptom? We kind of touched on this too. So just to be clear, the recipe, metformin and birth control are not the only treatments for PMOS.
I'm going to tread lightly here because I'm not stepping on anyone's toes that treats like that, but that is a little older school thinking, right? There's so much literature out there to support why we might incorporate different supplements or different treatments. Metformin only does so much, right? Now we see that we have these GLP-1 agonists and have even better ones like tirzepatide. And those are being shown to really help inflammation, even though it's anecdotal and they don't have research to support that. Every patient comes in, we see a drop in the CRP. We see them say, I don't feel that inflammation that you're describing, that feeling of inflammation. We sometimes will combine those therapies or use that instead of a metformin. Was limiting and had some side effects that patients didn't like. We also see that this is where the functional medicine component comes in. There's a lot of nutritional deficiencies that contribute toward this. Most of my PMOS patients need more magnesium than the average person. That helps make you more insulin sensitive, and it really works on your metabolic rate. Vitamin D deficiencies, especially your active form of vitamin D, can be very low, and that predisposes you to the depression that compounds this PMOS. And it's also hard to make your thyroid function more normally without a normal vitamin D level. Things like inositol that we've talked about can help you become more sensitive to your insulin. N-acetylcysteine is showing really good support in the literature to help make you more sensitive to insulin. It also works on that methylation pathway. There's just a lot of different things that we can add to, especially because things like GLP-1, we don't want to get so high on the dose that then you don't absorb food or you have GI side effects. I think we have a lot of different tools that we can use, and metformin is just a tool and we still use it, but we have a lot of other things we can add to that. With birth control, I just have decided that, it just shuts down your cycles altogether. That has shown a lot of long-term consequence. I don't know, looking back, how I might have prevented pregnancy without it. As a female, you will have to take that risk of what is right for you. There may be more bioidentical hormone ways to control, try to boost things like progesterone. Definitely using thyroid medication, and I mean like, desiccated thyroid, giving you T3 support can really help to boost your thyroid, which helps your ovulatory cycles. It also helps your metabolism. It helps the way you feel. It gives us energy. Just limiting ourselves to certain tools are inappropriate. Now we know so much about this. It does incorporate a trainer. I love when trainers are working with patients because it also keeps them, accountable and has a professional to help guide them of what workout might be right for you. And a dietitian or a nutritionist is going to help guide you on food. We can't all afford those things. Definitely talking about all of these things is going to be helpful for that patient, and the mental health component too. So much of this is, we think it's our fault, that we're here. And the depression coincides with this disease or this condition. We have to address that. And positive self-talk is a real thing, and it's hard for all of us to try to get in the habit of that, and then adding things like vitamin D to help us not feel so depressed.
At the house.
Yeah.
Sometime, Go out in nature.
Yeah. Be outside, get some sunlight, right? Get off of our phones, the EMF exposures. There's a big source of literature coming out that shows these endocrine disruptors that really affect our hormones, and our leaky gut is contributing to us absorbing that extra estrogen. And now maybe we have normal levels of estrogen in our body, but we have higher levels floating around not knowing where to go because something else is tying up that receptor. It is a complicated system, right? I couldn't imagine trying to treat with just one viewpoint because it's hard enough having a holistic perspective.
Does having PMOS mean your testosterone is always high?
No, that's a misnomer. That you can have PMOS and not have elevated androgens, testosterone or DHEA. We see that a lot, and especially see that in women coming into me in that perimenopausal age range. They're starting to see drops in the testosterone, and maybe when they were younger it was higher, but it is more of a side effect. You also have to know that the testosterone could be normal. We could have things that are binding it up or not binding it up, right? If it's not being bound, maybe that normal testosterone looks normal, but the free testosterone is high. So sometimes you have to really look at the whole picture of it to see, does that patient truly have high androgen levels, or is it high free levels, or are they normal? It's also a misnomer that women who have PMOS can't take testosterone as they get older. Of course, we know testosterone isn't FDA approved for women yet. It will be, but in perimenopause and menopause, testosterone can be very, very helpful. So you want that person to understand that just because they may have had high levels when they were younger doesn't mean they can't replace when they're older if they lose it, right? So we always want to go for that kind of balance of the hormones. They don't have to have it to be diagnosed with it.
Is PMOS just a weight problem disguised as a medical condition?
No, it's endocrine, it's mental health, it's cardiovascular. I always say this is we have to take it seriously because those women are higher risk of breast cancer, endometrial cancer, heart attack, stroke, cognitive decline, but depression, We see women enter into perimenopause and we get in our mid to late 40s, suddenly our cognition starts to decline. Our hormones are changing rapidly. We already had underlying depression and we're overweight, and we start to get higher cholesterol because we're losing estrogen, higher heart risks. And then you go to a provider and they're like, oh, just lose weight and exercise. That's depressing. And so I worry about the mental health aspect of it. I worry about divorce rates. I worry about the spouse not understanding what that woman is going through, because perimenopause is hard enough already. I haven't been through menopause yet, but I think perimenopause might be harder. Add to that PCOS, PMOS, add to that a weight issue and a depression issue. And I worry that we don't make it through these years, right? That's a big fear. Or that we become more introverted. And we see that a lot. Do you see the old women that are in their house, they don't leave, right? They won't go stay in someone else's bed. We all have a grandma like that, right?
Yeah.
We don't want to be that grandma, right? We want to be the grandma that is interacting with our family. We want to be the traveling retired person, right? We want to go and live our life. And so I think that we have to address it because we have to start talking about heart disease in women. That's the number one killer. We are so focused on breast cancer that we're mammogramming everybody, but why are we having heart attacks and strokes, right? What are the risk factors? They start now. And what might impact us from enjoying the years of our life when we have more knowledge. We actually have something to say and we have an opinion on it.
We can get around.
But we might be too moody and it comes off wrong, right? Our husbands don't understand. So we have to really support these women. It's hard.
So it's something that they just need a little help with or a little boost.
Yeah, there's a physiologic reason behind it. And to me, that's rewarding to understand and to convey to women. I have women come in and they cry because they say, no one's ever at least explained this to me and told me that there's a valid reason for the way I feel. And there's an actionable item that we can take and step toward it. And experiencing that moment where you realize, okay, this could impact me in having a heart attack, a stroke, or diabetes, or cancer. Those are reasons to change. It's not always enough that your clothes don't fit because maybe that's always been the case, right? But sometimes you say, oh wow, I don't know what I would do if I had a heart attack right now. How would my family eat? How would they survive? And so I think it's important for us to realize that that's what we're trying to prevent is this, big devastating consequence that then, we're in the hospital and we're forced to make a change. Let's make it beforehand, but let's realize that there's some actionable items that we can take. There's a whole picture that we can look at.
Can you have PMOS and still have regular periods, and does it get worse as you get older?
Yeah, it can. You can have PMOS and at different times in your life. Maybe your periods feel regular. Maybe you don't notice the anovulatory cycles or the kind of oligomenorrhea where it's like coming too early or too soon. Some people sort of feel like that was always normal for them. Sometimes they'll feel like, okay, in high school and college, maybe they're a lot more active because they're an athlete. That keeps them more insulin sensitive and it keeps their weight down, which might control their periods. Then they might get into a phase later on in life where they're really busy at work and suddenly all that exercise and diet goes out the window. Maybe they travel a lot. That's the moment in their life where things are going haywire. It's definitely going to ebb and flow depending on what stage of life you're in. Sometimes it comes out in the form of gestational diabetes during pregnancy. Maybe that's their first clue that they had something going on. Maybe they were on birth control all the way up to the moment that they tried to get pregnant. And sometimes they have postpartum depression after they have a baby. Sometimes they couldn't get pregnant, and maybe that's the first clue that something's going on. Or they had a row of miscarriages. Any of those points in time could indicate that this is where it's not as controlled. Perimenopause is a big moment where we realize a lot of this PMOS is kind of rearing its ugly head because you'll see things on someone who's younger and you'll go to realize it's not that they have premature ovarian failure, it's actually PCOS that just looks like that, and there are specific tests you can use to tell. Just remember that we're trying to look at this with a really holistic image and trying to look at all of the, in functional medicine, we work with what's called a matrix, which is like all the nodes in your body that are impacting you. We want to touch on all of those things. That's why it's hard for me because I would love to try to lower the price and have more people come in, but you can't look at all the nodes of the matrix when you're starting to see a person in 15 minutes. And so you miss a lot. And the main thing is you really want someone that's going to take a deeper dive with you with PMOS. You might start a GLP-1, it may not impact you at all. And that's very disappointing for those patients because it was a big step for them to even get on it. And then just to realize, oh, it didn't do what I thought it was going to do. So you need that extra help, and it's okay to ask for that.
There are a lot of factors, especially just being woman and then PMOS on top.
The same guy will come in and we start them on a few hormones or, start them on a nutrition and exercise plan, and they come back 3 months later in a total V-shaped, dad bod gone. That wife of that patient comes in and she's like, I haven't changed at all. It's really hard to be a woman, especially in our older years. It's just okay to start talking about that more. Recognizing that we need support. We need more people talking about it. We're just at the tip of the iceberg with PMOS research. There's a lot of good information coming out, but it doesn't make us experts at it. It means we need to keep going, keep searching.
Again, thank you so much for talking with me about PMOS. I am a patient of Melanie Frye. I'll put her information in the description, and that way you can reach out and speak with her. And when you sit with somebody, I think it's easier when somebody can say so much, but when you have a personal experience with them, I can tell that she really cares about what she does. Obviously, you can see it in how she talks and what comes out. And I greatly appreciate that. And I can tell you from the email that she sent with all of our notes, I knew that there was something different about you and about this appointment. So again, I thank you for meeting with me to discuss this, because it'll help so many people.
And I thank you for sharing your story, because it's hard to talk about it, right? We're talking about things that are hard to discuss, and people are private. So I think you sharing your story and seeing your journey, the good, the bad, and the ugly, is important, just to get more information out there. Yeah. It's important to reach out. It's hard because I do defend Western medical practitioners. If they're accepting insurance, insurance is telling them they have 6 minutes. It's not their fault, but it is the system they've chosen to be in. That's why functional medicine, you're paying for time. Mm-hmm. You're paying me to go to the books and research. You're paying me to say, I'm not sure, but let me look at that. That's hard. Not everybody can afford to do that. And the hope is that videos can kind of get out, and there's so many things that people can change, just at home, and at least work on in case they can't afford that. Thanks for sharing. I think it's going to impact a lot of people.
Thank you.
Awesome.
Appreciate you.